Yat and welcome to Four Directions of Wellness. I'm Roberta Diswood. Twopahanishla, Sisakadni Bashichin, Nakaidina Dejache, Hanahni Dashanele. The National Center for Health Statistics estimates more than 130 people in the U.S. die every day from opioid-related drug overdoses. The Center for Disease Control has identified that American Indians, Alaska Natives, had the second highest rate of death from opioid overdose in 2016. And in 2017, Health and Human Services declared the opioid crisis a public health emergency. The Shiprock Service Unit in 2016 organized a chronic pain management committee to address the opioid crisis. Since then, prescription pain medication such as opioids has been reduced by 50%. With us today to discuss the committee's efforts and changes in chronic pain management is the committee chairperson, Dr. Thomas Quattlebaum. Dr. Quattlebaum, thank you for being here today. Can you tell us a little bit more about yourself?
Sure. Thanks for having me. My name is Thomas Quattlebaum. My clans are Vietnamese on my mom's side and Bilagana on my dad's side. I'm a family medicine physician here, and I am the chairperson of the Chronic Pain Management Committee.
Well, again, thank you for being here. So why was the Chronic Pain Management Committee formed?
So there were a lot of reasons. Part of it is in response to the opioid crisis, as you mentioned, and part of it was a need on our part to better manage chronic pain in a more systematic and holistic way. So one is we wanted to reduce the opioid prescribing to improve the safety and health of the patients here, and then also provide resources for the providers here to better manage chronic pain through both education as well as direct kind of case-based recommendations as well.
Mm-hmm. And so who is on this committee?
So it's a multidisciplinary committee. We have practitioners from all different fields. So we have medical providers from family medicine, internal medicine, mental health, mainly psychiatry. And we also have pharmacists, physical therapy, representatives from the substance abuse program, as well as nursing and case management that all participate in the committee.
Okay. And so what is the purpose of this committee?
So the purpose is several-fold, like I said. So one, I think the primary purpose is to improve the way that we manage chronic pain as a whole at the service unit and provide the resources to providers as well as patients on how best to manage chronic pain, because we know it's changing. Mm-hmm. And then second is to make sure that we're following the safe way of prescribing opioids and keeping our patients safe from harm as well, so we don't want to worsen the overdose and opioid addiction problem that's present in the country.
Mm-hmm. So how is Shiprock Service Unit changing the way that it treats chronic pain?
So several different ways. So we know now that medicines are probably not the best way to treat chronic pain, and it takes a variety of different treatment approaches. So we're focusing on incorporating all those approaches into the care of each particular patient. So it's going to depend, of course, on what the condition is, how we treat it. So medications are, of course, one part of it, but we want to focus more on using other types of medicines besides opioids to treat pain. And so we've expanded our formulary so that there are different options available now, whereas before they were a little bit too costly, but now our committee has helped to get those available for patients. And then we're incorporating more physical therapy modalities, working with mental health to try and get some of our higher risk patients in sooner, and collaborating more directly to try and meet the patient where they are. So if they're coming in for a primary care visit, then we can try and have the psychiatrist come over to meet them at the same time instead of having to schedule separate appointments. We've also have new modalities that are introduced here, like something called osteopathic manipulation therapy, which is a treatment done specifically by a type of doctor called an osteopathic doctor. So we have that available for patients. And soon we hope to have acupuncture available, hopefully starting beginning of 2019. And then we're also partnering with traditional healers, both at Four Corners, and we just have one that started here at Shiprock recently. So all of those ways I think are important to combine and to try and treat the patient as a whole.
Mm-hmm. So you mentioned earlier when we were talking about like treatments and stuff and alternative treatments, you mentioned physical therapy modalities and also osteopathic. treatments. What are those? Could you explain a little more?
Sure, yeah, those are good questions. So different modalities that physical therapy can offer include, one is just education. So they've actually done research that shows when patients are educated about the way pain is processed in the body and how chronic pain works, that they can kind of empower themselves to take control of their pain and then have better management of their pain. So that's one thing, just education, and we have several physical therapists trained in what we call therapeutic neuroscience education. So basically education about the way pain is processed in the body. Mm-hmm. And then of course they do standard types of physical therapy things involving core strengthening, kind of addressing any imbalances in the way people walk or carry their body. And they're also doing some types of what we call more like manual or direct therapies with placing their hands on the patients, and sometimes even what we call trigger point injections or dry needling, which involves putting a needle into areas where the patient is experiencing pain. Mm-hmm. And then you asked about osteopathic manipulation therapy, which that is a type of manual therapy. So basically the doctor will put their hands on the patient and adjust or manipulate certain areas to either improve the way, improve the posture of the patient or improve the balance of the patient's muscles. And so there's various different types of specific techniques, but that's kind of the basics of it. The doctor will be putting their hands on you to adjust things. Is a kind of a simple way of describing it.
Okay. All right. Well, thank you. The National Survey on Drug Use and Health reported 2.1 million people have an opioid use disorder, and HHS declared the opioid crisis a public health emergency. So if you could help me, first, what are opioids?
Also a good question. So opioids are a type of strong pain medicine that basically block pain in the body. So if someone takes an opioid, they will reduce the sensation of pain in the body. It doesn't make the cause of the pain go away, but it will make us not feel the pain necessarily. They are a controlled substance, and some common ones include things like morphine, hydrocodone, oxycodone, and codeine for prescription drugs. And then there's also illegal drugs like heroin that is also considered an opioid.
And so how do people become addicted to these?
Various ways. So one of the more common ways actually is from getting a prescription from their doctor for an injury or something that caused them pain, and then a certain percentage of those people might get addicted to it based on that, because when people take opioids, they tend to cause what we call a euphoric effect, or a feeling of getting high. So it feels good, and then some people want to keep getting that feeling. The vast majority of patients, I think, do not get addicted, but there are some who do. From that way. And then other people kind of cross over from different substances and either take pills that were prescribed to their friends or relatives, which we're not supposed to do, and then that can kind of get them into the pathway of experiencing those drugs.
Mm-hmm. And so when we talked earlier, people are dying from opioid-related overdoses at an alarming rate. And what is our service unit doing to combat this?
So yes, we are definitely concerned about that. So we're doing a lot of different things. First off is kind of a primary preventive, which is reducing the amount of opioid prescribing in the first place. So trying to really identify when are opioids really needed, and then only prescribing them in those certain cases, and then trying to limit the amount that goes out too. So we know we have more information now that we probably don't need to be prescribing as much opioids at once, even for like after surgery or in an injury or something like that. Most patients don't need them for longer than 3 days, and by a week, really most patients don't need them at all. So that's number one, prescribing less. The second way is to increase the access to a medication called naloxone. So that's a reversal agent for opioids. So if someone accidentally takes too much opioid, that will cause them to what we call have an overdose, which can lead to not breathing, and death is the worst case. So naloxone, if given soon after an overdose, can prevent that and bring the patient back, basically. So it's a life-saving medicine, and anyone can be trained to use it. It's very simple to use, and so the pharmacy is dispensing it to our patients, and also emergency personnel like EMS out in the community have access to it as well. One more thing that we're working on is using Suboxone, which is a medicine used to manage opioid addiction, and it's safe and it doesn't cause overdose like traditional opioids do.
You talked about naloxone. Are there anything that can go wrong with it, or anything about using it?
That's a good question. So no, not really. Even if a patient is overdosed from some other reason, or unconscious from some other reason like alcohol or another drug, giving naloxone won't be harmful to them regardless. And if it was opioids, then it should help them to wake up.
Okay. Well, that's really good to know, though, that especially about something like that. And, we talk about in healthcare, opioids serve a valuable purpose. When do we need it?
Yeah, so I think it's important to remember that opioids are not evil necessarily or overall a bad thing. There are some important uses. So one thing would be for patients who have cancer type of pain. That's won't go away. We know for that reason it's actually very effective and can help improve quality of life for patients. And then the other reason would be for like an acute severe injury or after surgery. And like I said before, even then it should be for a short duration. And then even in some of those cases, they've done some studies where in the ER they compare opioids to medicines like ibuprofen or Tylenol. And it actually seems like for a broken arm, for instance, and it actually seems like both do about the same job as each other, so they have equivalent pain control.
So it's just learning to figure out when exactly it's needed and not.
Right.
Okay. Well, to finish this show, I'd like to focus on the patient. When a patient has been on opioids for a long time and they may have developed an addiction, how do we change their medication and treat that addiction?
Yeah, it's a great question. So I think that, well, first of all, I think that most patients who are on opioids long term are probably not addicted. They have developed some dependence on the medicine just from being on it for so long, meaning their body is kind of used to it and it's hard for them to not be on it, which is a little bit different than addiction where they kind of crave the medicine and are going to other lengths to take it if they don't have it. So to treat the addiction, if it's identified, I think it's important to have open conversation with patients about it and express concerns. And same thing for community members. If you are worried about a family member or someone you know being addicted, I think talking to them about it, encouraging them to talk to their doctors about it is important. Mm-hmm. But we have lots of different ways to treat it. One of the kind of emerging ways is to use a medicine called Suboxone, which helps to block some of those cravings and also prevent the risk of overdose in patients. So a lot of times when patients get on this medicine, they feel like they can go back to having a normal life instead of constantly feeling the need to get opioid pain medicine. Mm-hmm. And then kind of along with that is involving mental health and other substance abuse counselors in having the patient talk about their issues is also really important.
Mm-hmm. And so when patients have been taking this, how do they usually feel when they stop taking their pain meds?
It's a very good question. So I would say from my own personal experience and from others' stories, the vast majority of patients either feel better after stopping or notice no difference. So most patients feel perfectly fine. There can be what's called a withdrawal period after abruptly stopping, but we try to work with patients to minimize that and kind of go down slowly on their medications. And then some patients even told me afterwards they didn't even know why they were taking the medicines in the first place and feel a lot better, feel like they're kind of out of a fog, don't have to deal with some of the side effects that opioids cause, like constipation, drowsiness, just feeling tired all the time. Mm-hmm. So yeah, I'd say most patients feel either better or the same.
Well, I want to thank you for being here today.
Okay, thank you for having me.
This has been 4 Directions of Wellness, Hagonet.